So we'll use the really small computer thing. So basically, our body makes antibodies, and they're produced by the B cells in response to some sort of antigenic stimulation. And then with the advent of technology, we have the technology to produce exogenous antibodies, and we use a lot of those in malignancies, not just heme malignancies, but throughout solid tumors as well. And some of the early products were polyclonal products, and basically derived from many different types of cells, not necessarily specific as to what type of antigen they bound to. And now, obviously, most of our products are going to be more monoclonal in nature, so derived from a single clone of cells or a single source, and also more specifically targeted to a specific antigen on the cell surface. We do also have what we call immunoconjugates, and that's basically a monoclonal antibody that's linked to some sort of toxin, and so we'll talk about those more specifically.
Let me get one more shot.
Yeah? That's okay.
Did you get done? No?
You want me to restart, or no? We'll keep going.
No,
Okay. I'm sure that you guys have seen diagrams similar to this before, but basically a look at the technology of how we sort of generate our monoclonals. Typically, a lot of things are done through myeloma cells, and so you isolate the antigen, you mix it with the myeloma cells, hybridize them, and then you can get your specific verified monoclonal product of choice through this technology. And I'm sure you've seen this diagram 15 million times, but basically this is the generic structure of a monoclonal antibody. You have the constant region, which basically is going to determine the effector function, or what the ultimate end product reaction of the monoclonal antibody is going to be. So does it activate the complement cascade, or antibody-dependent cell toxicity? And then you have the variable region, which is going to determine what antigen the monoclonal antibody will bind to. And nomenclature, basically when you're trying to figure out, if you don't know anything about the product, you can use the naming conventions that have been established for monoclonals to determine the source. And so basically you start at the end of the product name, and it will end in MAB, which indicates it's a monoclonal antibody. And then the next portion immediately prior to MAB will indicate the source. So if it's an O, it's a mouse product. If it's XI, like rituximab, it's a chimeric product. And more of our monoclonals are the humanized type. So trastuzumab, for example. And here's a look at the difference in the structures of the different types of monoclonal products. So what you want to pay attention to in the picture is the amount of structure that's in blue. And so blue is non-human portions. And so with a murine product, it's entirely derived from a mouse. The biggest problem that we have with these particular products is the generation of HAMA antibodies, or human anti-mouse antibodies. They typically occur 2 to 3 weeks after the medication is infused, and basically it results in rapid clearance of the monoclonal antibody because the body recognizes it as foreign and wants to get rid of it. It can cause severe reactions such as anaphylaxis in some patients, and typically we are limited by these products because we can only administer them one time, because the vast majority of patients, as you give subsequent doses, will generate HAMA antibodies and make the product ineffective. With chimeric products, you can see that we have less blue and more gray on the structure, and that's because we're introducing more human components to the product. And the biggest advantage is that typically it's going to result in less immune response compared to murine products. And we also can be a little bit more specific as far as targeting specific antigens, and also are better able to drive what happens as a result of the antibody binding to the antigen. It also changes the kinetic, the pharmacokinetic and pharmacodynamic parameters of the products usually, in that they typically have a longer half-life, so they stick around in the body for a longer period of time. With human products, you can see that with these products, typically 90% or more is human, and the rest is typically mouse. And this is the type of monoclonal product that's going to have the lowest incidence of HAMA reactions. And, you know, one of the biggest things is we can use these types of products in patients that have had previous reactions to a chimeric monoclonal antibody. So if patients have had reactions to a product like rituximab, you still want to use a monoclonal product. Humanized monoclonal antibodies are still an option. And this is just a comparison of the various antibody structures all on the same slide, so that you can see the difference. As you go from murine to humanized, you get more human component, less murine. And then also looking at the immunoconjugate structure in the bottom middle of the screen, and shows how the monoclonal structure is linked to the conjugate structure, which is usually the more toxic portion. And so currently we have one of these agents on the market. We used to have two, Mylotarg or gemtuzumab, which was removed from the market. And now brentuximab is the only immunoconjugate that we have available. And typically, the monoclonal structure is linked to either a drug or some sort of, I guess it's not the only product, but the only non-radioactive product. So it's linked to
DM1.
Heme malignancies.
Oh, got it.
Sorry, I'm talking about heme malignancies. And so basically, the goal is that these are potentially more efficacious because the way that the monoclonal binds to the target cell and then incorporates the more toxic portion of the molecule into the cell itself. And typically, a way to determine if it is an immunoconjugate is usually the products have two names. So you have brentuximab vedotin, which is an example. Brentuximab is the monoclonal part, and indicating that there's some other piece, which is usually the conjugated part. As far as what sort of responses we have to antibody products, we can have direct tumor effects. So monoclonals themselves can induce cellular apoptosis. They can affect how other ligands bind to receptors on the cell surface. They can determine or potentially modulate cytotoxic effects of a second agent. And then probably the biggest mechanisms in heme malignancies in particular are complement-dependent cytotoxicity and antibody-dependent cellular toxicity. So here is a picture, and on the far left you have the tumor cell that expresses the target antigen, and you have the monoclonal antibody binding to that particular antigen on the cell surface. And then with antibody-dependent cellular toxicity, you have binding to the Fc portion of the monoclonal antibody that then draws in other types of cells like NK cells or macrophages. It ultimately will result in cell lysis. And with complement-dependent cytotoxicity, again, the Fc portion of the monoclonal antibody attracts complement proteins, and then that basically pokes holes in the cell, which ultimately is going to disrupt cell homeostasis and result in cell lysis. The first that I'm going to talk about is rituximab, and I sort of feel like rituximab should be in the water on the 5th floor. We use it in a lot of different malignancies. It targets the CD20 antigen on the cell surface, and so is primarily used in B-cell malignancies. And here are the package insert approved indications: relapsed or refractory low-grade or follicular lymphoma, previously untreated follicular in combination with first-line chemo, also in previously untreated diffuse large B-cell in combination with CHOP or some other anthracycline-containing regimen, and then also in patients with LL in combination with fludarabine or in cyclophosphamide. And as far as mechanisms, we have antibody-dependent, complement-mediated, and then also direct cellular apoptosis. So as far as administration, one of the biggest issues, and you'll see this in a couple slides, is the risk of infusion-related reactions, which can occur in up to 80% of patients with the first infusion. So this is something that comes up a lot in the clinic, but what's the difference between the 3 different infusion options that we have? And so you can see with the first dose, so a patient who's never received rituximab, start the infusion at 50 milligrams an hour. You increase it by 50 milligrams an hour every 30 minutes if the patient's tolerating it, to a max of 400 milligrams per hour. And with subsequent doses, and so this is non-rapid infusion, you can initiate the infusion at a higher rate of 100 milligrams per hour, and it can also increase by a higher rate of 100 milligrams per hour to a max of 400 milligrams per hour, assuming that the patient is tolerating things. And so this is more a pharmacy thing, but as far as total volume, typically with either the first dose infusion or standard non-rapid infusions, we would typically make it as a 1 milligram per mil infusion. So if you're giving a patient an 800 milligram dose, the patient would be getting 800 milliliters of fluid. We do have the option for rapid infusion, and so I have the criteria for those patients on the next slide. But basically, we would give the patient 20% of their prescribed dose over the first 30 minutes, and then would infuse the remaining 80% over the next 60 minutes. That is for patients that receive doses less than 1,000 milligrams. For patients that get doses larger than 1,000 milligrams, we actually would put it in a volume of 500 mils, and their infusion would be over 3 hours instead of 90 minutes. So shorter than the middle column, but still longer than what we typically think of as rapid. So our rapid infusion criteria here at Duke is for patients who are receiving Rituxan specifically for an oncology indication, and they have not experienced a grade 3 or 4 infusion reaction with prior infusion. And if a patient has previously been treated with rituximab, but it has been 3 months or longer since the last rituximab dose, then the patient unfortunately has to go back and start at the first standard infusion, which typically is over 3 to 4 hours depending on the dose. I will say that 3-month timeline depends a little bit on which infusion center pharmacist you talk to. So, if it's been 3 months and a week, a lot of times they're willing to go ahead and do the rapid. Our policy specifically says that patients on clinical trials are excluded from rapid infusion, and again, I will say that does not always hold true. I know with one of Dr. Bevan's studies, patients get standard slow infusion with the first infusion, but because it's investigator initiated, she has allowed us to do rapid for subsequent infusions in those patients. So that's necessarily something you guys have to worry about, but it's not always a hard and fast rule. So as far as dosing, there are lots of different options, and it really depends on the indication for rituximab. Typically, with non-Hodgkin's lymphoma or B-cell malignancies, the dose is 375 milligrams per meter squared, and that can be weekly or that can be per cycle, depending on how you're administering it. With ALL, and this is where you tend to get into patients who might have doses higher than 1,000 milligrams, they typically will give 375 milligrams per meter squared on the first day of cycle 1, and then we'll increase to 500 milligrams per meter squared with cycle 2 and beyond. The other thing that is a pharmacy-specific policy is your dose will be rounded to the nearest 100 milligrams. And so if your dose calculates out to 652 milligrams based on the patient's BSA, we would round to 700 so that we're not wasting part of a 100 milligram vial. So that's just an FYI, and I will say for the most part that seems to work well in the treatment plans that are in Beacon. Some other things don't round well, but rituximab does seem to round appropriately. And as far as toxicity and monitoring infusion-related reactions is really one of the biggest things that we watch out for, and this slide can be repeated for several medications in the next couple slides, but pre-medicate patients with typically Benadryl, either IV or PO, depends on which practitioner you're working for. Certain practitioners will do both IV and PO Benadryl, thinking that the IV Benadryl takes effect more rapidly, and by the time that the patient is probably most at risk, then the oral Benadryl would also be on board. I don't know. I guess I think you should pick one or the other, but it doesn't seem like the thing to get upset about. So other providers hate IV Benadryl and only give people oral, so it just sort of depends. There also is wording within the package insert because of the risk of hypotension during the infusion-related reactions to consider holding antihypertensives prior to the first infusion. I will say most providers in the HOA clinic don't usually do that. Then tumor lysis syndrome, we would manage just like we would any other patient with tumor lysis syndrome. Sometimes the HOA providers will hold rituximab with the first cycle of treatment in patients that have a large burden of disease because they're concerned about tumor lysis. You would manage with fluids and allopurinol resveratrol just like anyone else. And the potential for skin or mucocutaneous reactions, and then hepatitis B reactivation. And all of our treatment plans do recommend to screen patients for hepatitis B prior to initiating rituximab. Compliant we are with that recommendation? I can't vouch for, but. The next agent that I'm going to talk about is ofatumumab, or Arzera is the brand name. And this is a human monoclonal antibody that also targets CD20. It is specifically indicated in CLL patients that are refractory to either fludarabine and/or alemtuzumab. And again, works through antibody-dependent and complement-mediated toxicity. And it thought that the complement-dependent mechanism is stronger when compared to rituximab. And part of that is because of where it binds to the CD20 antigen. It binds to both the small loop and the large loop of the CD20 antigen on the cell surface, whereas rituximab binds to just the large loop alone. And so it's thought that this is potentially why, if you have patients who, one of the reasons, not the only reason, but one of the reasons why, if you have patients that don't seem to be responding to rituximab, then something like ofatumumab could still potentially be effective. Dosing with ofatumumab can be a little bit, dosing and administration, I guess, is more of the challenging aspect, but typically it's administered weekly, and the first dose is 300 milligrams, and then doses 2 through 8 are 2,000 milligrams. Patients typically will have a 4-week break in treatment, and then they get another 2,000 milligram dose once a week, every 4 weeks, for a total of 4 doses. So they get a total of 12 doses of treatment, but it's over a longer period of time. And with ofatumumab, so your pre-medication is slightly different in that corticosteroids are recommended. Per the package insert right off the bat, you don't wait to see, like with rituximab, you would do Tylenol and Benadryl, wait and see if the patient has a reaction, and on steroids, if necessary, versus ofatumumab, you would give patients some sort of steroid right off the bat. Similar to rituximab, your infusion rate starts slow and you titrate every 30 minutes, assuming that the patient is tolerating the infusion. Of note, ofatumumab is not something that you can just order and it will automatically be administered to the patient. It's one of the 6 or 7 drugs that we have on the pharmacy side classified as high cost. So if you want to administer ofatumumab, you have to get prior financial approval in order to do that. Not a hard process, but they get a special number that's documented in their chart before they'll let you administer the medication. As far as toxicity and monitoring, again, infusion-related reactions are the big problem, typically with ofatumumab, and patients are typically in the treatment room for anywhere from 6 to 8 hours with their first and second infusion. Tumor lysis syndrome, again, is a possibility. Also, probably more of a risk of cytopenias with ofatumumab administration as compared to Rituxan. And you have the black box warning for hepatitis B reactivation. The other thing that I will say we have seen perhaps a little bit more frequently in clinic is paresthesias. And so Mark Linesa is probably the biggest user of ofatumumab. It's not really anywhere in the package insert or documented very well, but something that he has seen often enough in his ofatumumab-treated patients to attribute it to the ofatumumab. So last week we had a patient coming in for dose 4 or 5, and she had noticed some numbness and tingling around her lips and in her fingers. She attributed it to a platelet transfusion, but Mark thinks that it's probably actually the ofatumumab causing it. So.
Sorry, is this infusion or like afterwards? Or
no, so it's actually, I mean, it's not temporally related to the infusion necessarily, I don't think. Because she had been noticing it sort of off and on all week, and it wasn't anything that was interfering with her activities at that point, but you know, she would be sitting and she would notice some tingling and things like that. But obinutuzumab is the newest agent that was approved on Friday, and thus far, as indications, it is indicated for CLL patients in combination with chlorambucil. And so this is, mechanistically, it still is targeting CD20, but basically what they have done is what they call glycoengineering for the constant region portion. So basically, it's going to demonstrate enhanced antibody-dependent cytotoxicity compared to rituximab or ofatumumab, and less reliance on complement-mediated mechanisms or direct cell death, or less complement-mediated, and also probably more increased direct cell death. And so that is specifically how the product was engineered to try and enhance that aspect of toxicity. It's based on, the approval was based on data from the CLL-11 study, and basically there were 3 arms in this particular study: chlorambucil by mouth day 1 and day 15, GA101 or the obinutuzumab plus chlorambucil. You can see the dosing there was 100 milligrams on day 1, 1,000 milligrams on day 8 and day 15, and then just 1,000 milligrams on day 1 for subsequent cycles. And based on tolerability within the study, that dosing was actually changed somewhat, and so I'll talk about that in a little bit. And the third arm was rituximab and chlorambucil, standard CLL dosing of the rituximab. And so this is data that was presented at the ASCO meeting in June, and then planned final results should be presented at ASH in December. And you can see that the overall response rate was highest in patients that were receiving the combination of GA101 and chlorambucil, and you had 22% complete response rate. And based on the median progression-free survival of 10.9 months versus 23 months, is where the approval for GA101 came. And infusion-related reactions occurred in 21% of patients. You can see higher incidence of neutropenia. Infection risk is about the same between the 2 groups, but this is the data that allowed it to get approved. As far as dosing, the approved dosing is 100 milligrams on day 1, 900 milligrams on day 2, and then 1,000 milligrams on day 8 and day 15, along with chlorambucil on day 1 and day 15. And then on cycles 2 through 6, you just do a single dose of the obinutuzumab on day 1. So I think administration during the first cycle will be, I don't think necessarily that it'll be challenging, but just something that will obviously require more frequent patient presentation to clinic and a little bit more explanation. As far as infusion rates, with the day 1 100 milligram dose of treatment, you start 25 milligrams per hour over 4 hours, and you don't increase the infusion rate at all. With day 2, you would start at a higher rate of 50 milligrams per hour, and you would increase by 50 milligrams per hour every 30 minutes to the max rate of 400 milligrams per hour. So sounds a lot like rituximab infusions. And then with your subsequent doses, you would start at 100 milligrams per hour, again increasing by 100 milligrams per hour to that max rate of 400. Similar to ofatumumab, pre-medication for each infusion, Tylenol, Benadryl, and then also some sort of intravenous corticosteroid, whether it's Dex or methylpred. As far as whether or not we can change those on subsequent infusions, it's basically based on how well a patient tolerates their first infusion. So they'll always get Tylenol. They will get diphenhydramine if they have any sort of infusion-related reaction. And then if they have a grade 3 or higher reaction or lymphocyte count 25,000 prior to the next treatment, they would get steroid pre-medication prior to that dose. again, this slide that should be looking familiar by this point. As far as toxicity, infusion-related reactions, tumor lysis syndrome, neutropenias, and then the similar black box warnings for HVP and then also PML. The next agent that I'm going to talk about is alemtuzumab or Campath. And so you'll see this in patients with B-cell CLL who are not responding to therapy. And I will say, we see this occasionally, but with the advent of newer agents for CLL, I would say that this has definitely fallen by the wayside, but we will use it occasionally in patients that have had other therapies or are not eligible for clinical studies. It's fairly toxic and not really easy for patients to tolerate, so it's definitely not one of our first-line choices. Biggest issue that people have with it is infusion reactions, and you can give it IV or sub-Q, but with sub-Q you also have the chance of injection reactions, and we have a couple patients getting sub-Campath right now, and one patient described his stomach as a big red beer belly, but he's had horrible reactions to the sub-Q. So hematologic toxicity, you frequently will see a drop in counts. And I would say that is one of the reasons that we don't use Campath all that frequently, is because patients with CLL who need treatment tend to have count issues already, and so you would just be giving them a medication that's going to cause additional toxicity in that respect. Opportunistic infections is the other concern, specifically PCP or PJP pneumonia, and then herpes infections. And so you want to make sure that patients are receiving appropriate prophylaxis, and that should continue for at least 2 months after their last dose of alemtuzumab was administered. And that should be built into all of the treatment plans as a prompt to remind you that you need to cover for those various infections. With Campath, you do dose escalation. So typically, we treat patients 3 times a week, Monday, Wednesday, Friday, and you start with 3 milligrams. You then dose escalate to 10 milligrams, and then your target dose is 30 milligrams 3 times a week. And then your duration of treatment is obviously going to be based on response and how patients are doing. As far as the infusion-related events, typically they decrease as patients are on therapy. So they're highest during week 1, and then you can see they decrease in week 2 and beyond. If you have a patient that has been off of therapy for more than 7 days for whatever reason, you do need to repeat the dose escalation part. So their last dose was 30 milligrams. It's been 10 days since they got any treatment. You can't just go back and give them 30 milligrams. You need to restart at the 3 milligrams and titrate up. The other big question or mystery is actually obtaining alemtuzumab. It's not commercially available under the name of Campath anymore because they're rebranding it for treatment of multiple sclerosis. So they do have a special distribution program. So you can still get it for patients who have T-cell PLL or CLL. Prescribers and pharmacies have to be enrolled. And then basically, in the world of pharmacy, we try not to keep patient-specific supplies of drugs, but this is one of the medications where we break that rule in that we only will get a patient-specific supply. We can't use that for any other patient. And so you have to fill out a little bit of paperwork. It's actually not really bad. It's not a horrible process. And you'll get a certain number of vials per shipment, and that will vary based on what indication you're using it for. So for patients who have T-cell PLL, you can typically get a larger supply at the beginning, and you can also have a longer duration of treatment as compared to patients that you're treating for CLL. And it's usually, the paperwork will say allow 10 days, but in my experience, it's been a much faster process. So we filled out paperwork last week for someone on Tuesday and had drug by Thursday. So it's actually fairly painless. And so I think we've had a couple patients that have come into clinic and outside physicians think, well, I can't get this drug anymore, so they send them to us, which is fine, but you can actually get drug, you just have to fill out a little bit more paperwork. I'm going to talk about immunoconjugates in heme malignancies, and so brentuximab, or Adcetris, is one of those agents that we use in heme malignancies, and it's indicated for patients who have Hodgkin's lymphoma that's relapsed after auto transplant, in patients that had multiple drug regimens that are not candidates for stem cell transplant, and then also anaplastic large cell lymphoma. And it is a anti-CD30 monoclonal antibody. And so basically what happens is you have your monoclonal antibody structure that binds to CD30 on the cell surface, and through endocytosis it gets into the inside of the cell, and you have lysozymes that break apart the MMAE, which are these little nodes, I guess. So they break it apart from the linker, and then that disrupts microtubule polymerization. So you have the monoclonal antibody, and then it's linked to the MMAE, and the MMAE is the part that is actually toxic to the cell. As far as dosing, it's typically 1.8 milligrams per kilo IV over 30 minutes, given every 21 days. The maximum patient weight that you would use to calculate a dose is 100 kilos. You don't usually see a whole lot of dose adjustments for monoclonals in patients with hepatic or renal impairment, but there are specific package insert recommendations for patients with hepatic or renal impairment, and that's related to the toxicity of the MMAE part. There are concerns about pulmonary toxicity, and so we would not give it concurrently with bleomycin. And again, this is one of those high-cost items that's going to require prior approval. As far as toxicity and monitoring, I will say it's a pretty well-tolerated medication. Peripheral neuropathy is, in the studies, one of the biggest things that patients complained about. There are dose modifications for peripheral neuropathy in the package insert. Infusion reactions are listed as a possibility, but I would say are not very common. Hematologic toxicity and myelosuppression, again, I would say is not horribly common. And I will say one thing, if you look in the package insert, it says to a maximum of 16 doses. We are sort of utilizing an off and on approach sometimes when we give patients brentuximab. And so if a patient has a response, disease response after 4 doses or 6 doses, we don't necessarily continue until we've completed 16 doses or we've reached unacceptable toxicity. But I would say more recently we've been giving that patient their 6 doses or whatever, watching to see what happens, and if their disease comes back, then we reinitiate therapy, and have still had responses in the patients. We also had one patient who sort of came to clinic PRN for their brentuximab. So he had cutaneous T-cell, and so he was, 4 or 5 weeks, his skin would get really bad. He'd come back to clinic, we'd give him a dose, and he went on his merry way. So that's not in the package insert, but we have been doing that with some degree of success. And then the last couple that I'm going to talk about are the radiolabeled agents. So basically, the biggest difference, on the left you have your chimeric monoclonal, and so it's binding to the target cell, and we've already talked about the mechanisms. With the radioimmunoconjugate, you still have the activity of that anti-CD20 monoclonal, but you then also have the radioisotope that it's conjugated to that causes radiation damage to both the target cell and also to neighboring cells. So the two products that we have are Bexar and Zevalin, and Bexar is indicated in patients who have relapsed or refractory CD20 low-grade lymphoma, who rest after or during rituximab therapy. It's only indicated for a single course of treatment and shouldn't be used as first-line therapy. And as I was doing research, I actually saw on their website that they're going to discontinue manufacturing and sale of Bexar. So the last day to schedule dosing is February 11th of 2014, and then I think you have like a 2-week window to actually administer the medication. But I was not actually aware of that until I was putting this together. So it's linked to iodine-131, and it has, that there's gamma radiation that you use for imaging, and then the iodine-131 is the radiotherapy portion. And as far as administration with radioconjugates is a little bit more complicated. Because this is an iodine-containing product, the patients do need to begin some sort of thyroid protective regimen the day prior to starting Bexar administration, and they should continue that for 14 days after their therapeutic dose. So on what we call day 0, or the start of the dosimetric step, the patient gets Tylenol and Benadryl pre-medications. They get their infusion of tocilizumab, and then infusion of iodine-131. They then, over the next week, have 3 visits on day 0, day 2, 3, or 4, and then day 6 or 7 to assess biodistribution of the radiolabeled product, and assuming that biodistribution is fine, somewhere between day 7 and day 14, they would then get a therapeutic dose, or their therapeutic step. And again, you would pre-medicate the patient with Tylenol and Benadryl, and do the infusion of the tocilizumab, 450 milligrams over 60 minutes, and then their prescribed calculated dose of the iodine-131. As far as appropriate thyroid protective regimens, the list of options, you do have a couple different options: SSKI drops, Lugol solution, or potassium iodide tablets. And the biggest thing is, you can see that the SSKI and the Lugol solution are administered 3 times a day. The patient has to have a full 24 hours of whatever thyroid protective regimen you've chosen before you should start the dosimetric step. And you continue that for 14 days after the therapeutic dose. So they're probably on therapy for approximately 3 weeks. As far as monitoring and or toxicities, there can be infusion-related reactions, so you would adjust the rate as you would with any of the other products. Black warnings for hypersensitivity, and also prolonged neutropenia and thrombocytopenia. Patients with the radiolabeled products typically will nadir somewhere around 4 weeks after treatment, and can stay myelosuppressed for several months, 3 or 4 months after they receive the agent. In pregnancy category X, there have been secondary malignancies reported, and then thyroid monitoring is recommended annually for patients that have received this product. The last product is ipilimumab or Zevalin, and so again, patients with relapsed or refractory low-grade follicular lymphoma. It's targeting the CD20 antigen, and basically you have the ipilimumab, which is the monoclonal structure, and then the tioxetin, which is the linker for the radioisotope. And then you again have gamma rays and beta particles, which allow for imaging and also do local radiotherapy. Similar to XR, patients can have infusion reactions, again, have the risk of prolonged cytopenias, and so you will see comments that if patients have a significant amount of bone marrow involvement or impaired bone marrow reserve, which isn't necessarily specified, then they would not be candidates for treatment with Zevalin. And then the risk of cutaneous reactions, similar to rituximab. And so it's still somewhat complicated, but it's a little bit easier to administer than Bexar. On day one, patients would get pre-medicated with Tylenol and Benadryl, and then would receive a dose of IV rituximab at a dose of 250 milligrams per meter squared. Day 8 or 9, they would come back for the radiolabeled portion. And so, again, pre-medicate patients with Tylenol and Benadryl, give the rituximab, and depending on their platelet count is actually going to determine what dose of the Y90 labeled Zevalin you administer to patients. So if they have a platelet count greater than 150,000, you administer 0.4 millicuries per kilo. If they have a lower platelet count of 100 to 149, you actually administer a smaller dose of 0.3. And that should be administered within 4 hours of rituximab. And if they have a platelet count less than 100,000, you would not administer the product. Again, you have the adverse reactions associated with rituximab. You would use appropriate radiation precautions, the risk of prolonged neutropenia and thrombocytopenia. And that is really all that I have. So, questions?